Part 3 Perioperative Care. Let's start with chapter number 21 Day Case Surgery. Day Case Surgery. Day surgery. The delivery of a surgical procedure on a day case basis offers advantages in providing significant benefits for both patient and healthcare providers. The removal of an overnight stay causes less disruption to the patient's domestic and social situation and provides significant financial savings to the hospital. In resource-rich countries, day surgery is now an integral component of healthcare delivery, while in resource-poor countries, day surgery is increasingly in popularity due to patient preference and healthcare reorganization. Day surgery is defined as the admission and discharge of a patient for a specific procedure within the 12-hour working day. Where a patient requires an overnight admission, then the term 23-hour stay should be used. Day surgery is a patient pathway, not a surgical procedure, and extends from first patient contact to final discharge. Okay, so in figure 21.1, elective day surgery pathway. First, the patient is referred by a referring doctor to a specialist consultation and then for the preoperative assessment. The diagnostics and optimization are done by both specialist consultation and preoperative assessment. If the patient is fit, then the surgery is scheduled and admission is done for the patient. Surgery is performed. Then for recovery, after recovery, there is successful discharge and unplanned overnight admission may also take place. At the step of specialist consultation, if the patient is not fit, then the method to return patient unsuitable for surgical or medical reasons can be done. Moving forward, success in day surgery requires each component of the pathway to be safe and efficient and to be performed in sequence. Unplanned overnight admissions are minimized by ensuring that the patient is informed and fit for the procedure. The procedure itself is achievable as a day case. The procedure is scheduled early on the operating list to allow safe recovery and discharge, and the home environment can support a post-operative ambulatory patient. Summary box 21.1 Definition of terms used in ambulatory surgery: outpatient surgery not admitted to a ward facility, procedure room surgery, surgery not requiring full sterile theatre facilities, day or same day surgery, admitted and discharged within the 12-hour day, overnight stay, 23-hour admission with early morning discharge, short stay surgery, admission up to 72 hours. Models of care: office-based care. This model common in North America and Europe, where diagnostics and ambulatory interventions are performed in consultation premises, allows patients ready access to high street care. The downside is that the practice is usually limited to procedures under local anesthesia with or without conscious sedation. The use of general anesthesia is limited as this requires additional equipment and personnel and raises safety issues in an isolated facility. Stand-alone day surgery facilities, where day case procedures are performed in isolated facilities either on a remote site or in the campus of the parent hospital. The workload is free from interference by emergency admissions. The spectrum of procedures performed is by necessity limited to those under local or regional anesthesia or minor to intermediate procedures under general anesthesia to avoid unplanned overnight admissions and the requirement to transfer the patient to the parent hospital, which may be some distance away. Self-contained integrated day surgery facilities. Though structurally part of a hospital, self-contained units have their own reception, ward, theatre and recovery areas and are functionally separate from the main hospital and potential disruption by emergency admissions. The backup facilities of the main hospital are readily available if required, so these units can undertake a full spectrum of day surgery procedures. The growing demand for day surgery can lead to capacity issues and there may be duplication of costly capital equipment where procedures are performed on both a day case and inpatient basis. Integrated day and short stay surgery facilities. This type of unit allows complete flexibility in the delivery of day and short stay surgery with the ability to embark on more challenging day surgery procedures or consider day surgery on less fit patients. The availability of overnight beds has its downside. The pre-assessment team may convert fewer patients from overnight stay to day surgery by adopting the easy option of keeping the more challenging patient in overnight. Moreover, the availability of beds rather than day surgery recovery trolleys put these ambulatory beds at risk for emergency admissions. While dedicated day surgery facilities are welcome, regardless of model, they are not mandatory for successful delivery of the day surgery pathway. Success does require a dedicated day ward facility where the staff can concentrate on the timely recovery and discharge of the day case patient. In mixed wards of day cases and inpatients, nursing and medical staff naturally prioritize the care of the less fit patient, and it may be easier to keep the day case patient overnight rather than ensuring an optimum discharge procedure. Selection criteria, medical criteria, age. There is no upper age limit. The physiological health of the patient is a superior determinant of day surgery success. Summary 21.2 Selection criteria for day surgery. Medical, use physiological rather than chronological age. ASA status over 2 requires careful review. Provided that the BMI is under 40, this alone is not a contraindication. Social, a responsible adult carer must be available for the first 24 hours of the elderly and patients at risk to covert bleeding. Home conditions need to be suitable. Ability to contact hospital in an emergency. Surgical, operations up to 2 hours. Recognized day surgery procedures. Ability to eat and drink within a reasonable time scale. Comorbidity. Day surgery requires traditionally use the American Society of Anesthesiologists classification, which is a crude evaluation of chronic health. Standalone units often confine their criteria to ASA 1 and 2 patients, while ASA 3 patients are more suitable for hospital integrated units. Patients with significant respiratory or cardiovascular disease should be reviewed by an anesthetist before being accepted for day surgery. Many patients who are fit but hypertensive are incorrectly excluded from day surgery. There is no evidence to support cancellation when blood pressure is below 180 by 110 millimeter of mercury. Diabetes. The incidence of diabetes is increasing worldwide. Patients with well tolerated type 1 and type 2 diabetes are good candidates for the well managed day surgery pathway. Control can be assessed by measuring their HbA1c with a level of below 8.5%, indicating good control. Diabetes is associated with potentially severe comorbidities such as renal disease, autonomic neuropathy, and cardiovascular disease, and so these patients must be assessed carefully preoperatively and managed by an experienced team. It is important to have protocols for the care of diabetic patients that have been agreed with the local diabetic team and to involve them in the care of more complex patients. Success depends on ensuring these patients return to normal eating and drinking and managing their own diabetes as quickly as possible in the post-operative period. Traditional care with placing the patient first on the list and providing them with instructions on management of their medication preoperatively works well. Those on morning lists can simply miss their morning doses of oral hypoglycemic medication or insulin, though they must be instructed to bring their medications with them and to manage any hypoglycemia as they would normally. Those on afternoon lists and those patients who are on more complex therapy such as continuous subcutaneous infusions can still be managed with input from the anesthetist or diabetic team. We'll just review the table 21.1. The American Society of Anesthesiologists ASA physical status classification. American Society of Anesthesiologists 1963. ASA 1 a normal healthy patient. ASA 2 a patient with mild systemic disease. ASA 3 a patient with severe systemic disease. ASA 4 a patient with severe systemic disease that is a constant threat to life. ASA 5 a moribund patient who is not expected to survive without the operation. Start with epilepsy. Diagnosis of epilepsy does not contraindicate day surgery. Patients who have well-controlled epilepsy should be managed as normal patients, though it is important to ensure that their regular medication is not omitted in the preoperative period. Patients who are on medication but remain poorly controlled need careful review and discussion with their medical and anesthetic teams. However, if they have suitable home support and the proposed surgery does not put them at risk, then they too are suitable for day surgery. Obesity. The body mass index BMI is calculated as weight in kilograms divided by the square of height in meters, kilogram per meter square, and obesity is defined as a BMI of more than 30. Oh, this is the chart, body mass index calculator. We can see on the left side height in meters is mentioned, down on the x-axis weight in kilograms is mentioned. So we can just see in the chart and find out the BMI. Traditional guidelines are conservative about obesity due to fears of intra and post-operative complications. Although there is an increased incidence of non-serious respiratory complications intraoperatively and in the immediate post-operative recovery period, the course of these patients is otherwise uneventful. They should, however, be managed by experienced medical and nursing staff. Hypertension, congestive cardiac failure, and sleep apnea are all more common in patients with morbid obesity, but in selected and optimized patients, BMI up to 40 for surface procedures and 38 for laparoscopic procedures are acceptable and achievable in advanced units. Patients established on nasal positive airway pressure for obstructive sleep apnea can be managed successfully. Anticoagulants. Patients are generally on oral anticoagulants due to atrial fibrillation, previous thromboembolism, or because they have a metal heart valve. It is therefore important to review these patients carefully before deciding to discontinue their anticoagulant for their operation. When it is felt that surgery will require its discontinuation, this should be discussed with their cardiologist and the risks involved explained to the patient. Social criteria. Safe and comfortable discharge home requires the patient to be accompanied by a responsible and physically able adult. A journey time to home of 1 hour or less is advocated, but the comfort of the journey rather than the time involved is more relevant. Home circumstances require appropriate toilet facilities and the means of contacting the hospital should complications occur. Surgical criteria. Patients undergoing procedures up to 2 hours in duration can safely undergo day surgery with modern anesthetic techniques. The degree of surgical trauma is an important determinant of success, with entry to abdominal and thoracic cavities confined to minimal access surgery. Whatever the procedure, the main requirement is that there is suitable control of pain and the ability to drink and eat is in a reasonable time scale. With day surgery now applicable to more major and prolonged procedures, patients should undergo a venous thromboembolism risk assessment and have prophylaxis provided if required. Preoperative assessment. The evaluation or optimization of patient's fitness for surgery is known as preoperative assessment and is best performed by a specialist nursing team with support from an anesthetist with an interest in day surgery. All elective surgical patients should be initially regarded as suitable for day surgery until proved otherwise. The assessment should be performed early in the pathway to allow time to optimize health problems before surgery. The consultation consists of a basic health screen to include the measurement of BMI, blood pressure, and an assessment of past medical history with current medication recorded. Appropriate investigations are performed to ensure the patient is fit for surgery. The patient and or their carer should be given verbal and written information regarding admission, operation and discharge. Summary 21.3. Preoperative assessment on all day surgery patients early in the patient pathway by a specialist nursing team and with anesthetic support. Perioperative management scheduling. With dedicated day surgery lists, major procedures should be scheduled early on morning lists to allow maximum recovery time. When the list is in the afternoon, the allocation of local or regional anesthetic cases later in the day helps reduce unplanned overnight admissions. When mixed lists of day and inpatient cases are planned, then day cases are scheduled first. The mixing of day and complex inpatient cases is not advisable. The complex case may be inappropriately delayed if the day case is scheduled first, and conversely, if the day patient case is scheduled later, there is a risk of cancellation or unplanned overnight admission for the day case. Anesthesia and analgesia. Successful day surgery anesthesia requires a multimodal approach to analgesia. While ensuring patients are given optimal dosages of anesthetic agent, the agents used matter less than the skill of the person providing anesthesia. Multimodal analgesia starts in the pre-operative period, and unless contraindicated, patients should receive full oral doses of paracetamol and a non-steroidal anti-inflammatory drug such as ibuprofen. Intraoperative anesthesia can be maintained by any of the traditional inhalational agents. Total intravenous anesthesia technique using propofol are also popular and offer the advantage of reduced post-operative nausea and vomiting. The use of intraoperative analgesia will depend on the procedure being performed. When available, the anesthetist should use short-acting opioids, fentanyl, alfentanyl. Careful use of these agents can minimize the incidence of post-operative nausea and vomiting. Where the choice is limited to morphine, This should be used in small doses, less than 0.1 mg per kg, to minimize sedation and post-operative nausea and vomiting. Wherever possible, a long-acting local anesthetic agent such as bupivacaine should be injected into wounds by the surgeon. Pain levels should be routinely assessed in the post-operative recovery area. Further doses of paracetamol, fentanyl or low doses of morphine can be used to ensure that patients are comfortable prior to return to the ward. Post-operative complications. The range of post-operative complications is no different from inpatient surgery. However, the fact that the patient is discharged home within a few hours of surgery requires proactive monitoring in the immediate post-operative period. Summary 21.4. Optimal analgesia and anesthesia. Multimodal analgesia with paracetamol and NSAIDs, if not contraindicated, should be given preoperatively. Use long-acting local anesthetic infiltration of the surgical wound. Careful dosing of inhalational or intravenous agents should be used to maintain anesthesia. Avoid long-acting opiates such as morphine to reduce the incidence of sedation and post-operative nausea vomiting. Reactionary hemorrhage is uncommon but requires careful consideration following tonsillectomy and laparoscopic procedures. Reactionary hemorrhage following tonsillectomy occurs within the first 6 hours and these patients should be monitored for this period. The danger in laparoscopic surgery is covert hemorrhage, especially in young fit patients who can lose over 15% of their blood volume before showing any cardiovascular signs of hypovolemia, tachycardia and hypotension. These patients require a high index of suspicion as the first signs can often be as subtle as slow recovery and mobilization or uncontrolled abdominal pain. When problems do occur, there should be clear escalation policies to ensure the patient is reviewed by the surgical team as soon as possible. Nausea and vomiting is not uncommon and should be managed actively to maximize successful discharge. Elective day surgery. For some surgical specialties, over 90% of their elective workload can be achieved in day surgery. As a result, teaching and training now routinely occurs on day surgery lists but requires structure and close supervision. As the spectrum of procedures has increased and become more challenging, many surgeons have increased their involvement in day surgery. This is important because safe and efficient day surgery demands the competence and skill of an experienced surgeon. Some surgeons have concerns regarding patient safety after discharge. The risk of post-operative hemorrhage occurring once the patient has returned home is often stated as a major reason to keep the patient in hospital overnight, especially where the abdominal or thoracic cavities have been entered. Reactionary hemorrhage commonly occurs in the first 4 to 6 hours after surgery, but the patient is unlikely to have been discharged home within this time period. It may be caused by slippage of a ligature or displacement of blood clot precipitated by a rise in blood pressure, coughing or increased mobility. Post-operative monitoring of vital signs should alert the recovery team to any underlying bleed. Secondary hemorrhage is defined as occurring at least 24 hours after surgery but usually presents several days later as it is due to post-operative infection. Thus, even if the patient had stayed overnight, these post-operative bleeds are still likely to occur once the patient has returned home. Figure 21.3. Active management of post-operative nausea and vomiting. So, if the patient comes with post-operative nausea and vomiting, give intravenous fluids to hydrate the patient 10 to 15 ml per kg over 1 hour and intravenous antiemetics such as cyclizine and prochlorpromazine. Review after 1 hour. If still a problem, then give a second antiemetic of different type, example ondansetron or dexamethasone. Patient is hydrated and can be reassured that no further active management is possible. Offer choice of admission or to be discharged home. Summary 21.5. Surgical hemorrhage. Reactionary occurs 4 to 6 hours after surgery and is caused by ligature slippage, clot displacement or cessation of vasospasm after mobilization or cuffing. Secondary occurs more than 24 hours and after surgery and is due to infection eroding a vessel. Good surgical technique requires minimal tissue traction or tension and good hemostasis. In day surgery, these attributes are even more important. The number and variety of surgical procedures performed on a day case basis is increasing year on year. Volume procedures in general surgery, where the British Association of Day Surgery considers at least 40% of procedures can be performed on a day case basis, are shown in table 21.2. Table 21.2. Volume procedures where 40% or more should be performed on a day case basis: abdominal, excisional or treatment of anal lesions, hemorrhoidectomy, primary and recurrent inguinal or femoral hernia, laparoscopic cholecystectomy, laparoscopic fundoplication, pineal needle sinus surgery, breast excision or biopsy breast lesion, sentinel node excision, genitourinary laser prostatectomy orchidectomy, circumcision, excision of hydrocele or varicocele or epididymis, orthopedic, Dupuytren's fasciectomy, carpal tunnel release, therapeutic arthroscopy of knee or shoulder, bunion operations, removal of metal work, vascular, varicose vein procedures, thoracoscopic sympathectomy. Summary 21.6 Successful day surgery requirements: minimal access techniques, good hemostasis, avoidance of unnecessary tissue handling or tension. Emergency day surgery. Many emergency surgical procedures are minor and non-life threatening and traditionally have been considered low priority for surgical intervention. The prioritization of more urgent cases to restricted emergency theatre slots may result in extensive delays for minor cases with unnecessary bed stays and preoperative starvation. Many of these cases, such as incision and drainage of abscesses, can be safely discharged home after their initial evaluation in the emergency department. They are provided with adequate analgesia and scheduled to return to the hospital at an appointed time the following day, suitably staffed for their operation. This allows same-day discharge for minor emergency procedures. If performed early in the day, the surgery rather than the pathway may be defined as day case. Some patients may by chance achieve a true day case pathway with admission, operation and discharge in the same day, provided they are admitted early in the day. There is no diagnostic delay and theatre slot is available. Others may only achieve day case surgery but not a day case pathway. If there has been diagnostic or clinical delay on admission, common procedures suitable for the emergency day surgery pathways are shown in table 21.3. The success of an emergency day surgery pathways is dependent on the identification of unallocated theatre slots. These may be planned where there is reasonable predictability of emergency cases or may arise on elective lists, either day case or inpatient due to patient cancellations. Emergency facilities may also be underutilized when there are delays in getting the more seriously ill patient to surgery. There is therefore an opportunity providing staff are available to utilize the empty theatre for a minor case before bringing the optimized sick patient to operation. This allows the ambulatory patient to be discharged on the day of surgery, provided discharge protocols are in place. This balance between clinical and managerial priority can be difficult to achieve without surgical experience, but forethought can permit a positive outcome for the quality of emergency patient care and the managerial requirement to shorten duration of stay. When designing an emergency day surgery pathway, traditional day surgery selection criteria are ignored, with clinical judgment used to determine whether patients are appropriate for day surgery. The only absolute contraindications are systemic sepsis, unstable diabetes, major comorbidities, and if parental, then oral analgesia is required. This is table 21.3. Common procedures suitable for emergency day surgery pathway: arthroscopy, biopsy, temporal lymph node, evacuation retained products of conception, irreducible or strangulated hernia, inguinal femoral paraumbilical, incision and drainage of abscess, axillary, groin, neck, perianal, piloneedle, K-wiring, finger or wrist, laparoscopic appendicectomy, laparoscopic ovarian cystectomy, reduction and internal fixation, tendon repair. This is figure 21.4. This is emergency day surgery pathways. A is planned preoperative discharge home with imminent return for day surgery. B is true emergency day surgery with the entire pathway of admission, surgery and discharge on the same day. And C is preoperative delay but surgery and discharge on a day case basis. You can see the flow chart. Discharge: the assessment of a patient. The assessment of when a patient is fit for discharge is best performed by trained day surgery nurses using strict discharge criteria. While post-operative review by the surgical team is encouraged, the discharge should not be delayed by failure of their timely attendance. A suitable supply of analgesics for the management of pain should be provided. Paracetamol, NSAIDs and codeine form the basis of the drugs available in many countries. And this is the table for discharge criteria. Vital signs stable for at least 1 hour, correct orientation as to time, place and person, adequate pain control with supply of oral analgesics, understands how to use oral analgesia supplied, ability to dress and walk where appropriate, minimal nausea, vomiting or dizziness, has taken oral fluids, minimal bleeding or wound drainage, has passed urine if appropriate, has a responsible adult to take them home, written and verbal instructions given about post-operative care, knows when to come back for follow-up if appropriate, emergency contact number supplied.